questions. She's actually
Okay, great.
So we're going to begin. I'll just say welcome to the Institute for Life Course in Aging here at the University of Toronto, and thank you so much for coming today. I just want to say that we're very pleased to have Dr. Deirdre Dawson here from which one will I say first? She is a senior scientist at the Lunenfeld Applied Research Unit at Baycrest. She's also related to an associate member of U of T and an associate professor in the Department of Occupational Therapy. Well, it's called Occupational Sciences and Occupational Therapy at the University of Toronto. And in her home department, Deirdre's been awarded the inaugural award for research supervision. And she also received an award for research innovation in 2009, so this last year. And she did her thesis with Dr. Donald Stuss from Baycrest, and looking at the determinants of recovery after brain injury, looking at a nice new integrated approach. So we're very happy that she's here with us now. She's been an adjunct scientist also with the Toronto Rehabilitation Institute since about 2006, and even participates in U of T's collaborative program in neurosciences, as well as a member, or an associate member, of the Ontario Heart and Stroke Foundation, their Centre for Stroke Recovery since about 2004. So we're very pleased that Dr. Dawson could be here with us today to talk about her research. So thank you for coming here.
Thank you. It's my pleasure. That's there's some sort of little yikes when I hear all this stuff. No wonder I'm tired. Okay, well, I'm really glad to be here. And I'm more comfortable talking standing up. I think it comes from years of lecturing, so if that's okay with the webcast and so on. So I did my doctoral work. I finished it just over 10 years ago, so it seems relatively recent, but in brain injury. And brain injury has really guided a lot of my thinking, the consequences of brain injury. For many years, but being at Baycrest, which is a center for aging, of course, I've been exposed to a lot of the issues with aging and recognize that there are actually some parallels, so I'm going to be weaving those into my talk today. And of course, as I age, I sort of get more interested in this topic as well. So I just wanted to start off by acknowledging the co-investigators on the work that I'm going to be talking about today, my research assistants and graduate students who've been involved with this work, and also the funding that's allowed us to do the work from the Drummond Foundation and the Ontario Research Coalition. So how I framed the talk today, I'm going to be addressing this question: how do we facilitate older adults' ongoing participation in meaningful occupation? And I realized that the rationale for this work comes from a variety of different places. So I like to think about them as threads. And my mother is a weaver, so this seemed very apropos when I thought about how I'd woven these threads together to come up with the rationale for this study. And so once I talk about these background threads, we'll talk about the study design, describe the intervention or the training that we're doing, and provide some preliminary results of the work, because we're actually in progress in this study. So thread one, executive functions, and this really comes from my background in working in traumatic brain injury. Now I should say right now, I'm quite happy to be interrupted as we go along if something isn't clear. I don't know what the usual format is, but if there's a question that comes up, please interrupt me, because I think some of these concepts may be unfamiliar. So actually I should ask that. What kind of backgrounds? Maybe I can ask people what backgrounds they're from. That'll help me too. So how many?
We're at a mental health drop-in center as social service workers.
Okay. All of?
Four of us.
Okay, great. And what about the rest of you?
Back in medicine, technology.
Okay.
Lifelong education.
Lifelong education, okay.
I'm retired. Economics is one.
Okay. Okay, so probably the whole area of executive functions is maybe not something you typically think about. It's a very common area of cognition to be damaged following a traumatic brain injury. And it's also very important to consider in aging, which we'll get into in a minute. So I thought I needed to start with, well, what are executive functions? And the easiest way to think about these are to think about what are the skills that a CEO does. And CEOs do very high-level things in an organization: planning, judgment, time sense, goal setting, monitoring, working memory, which means having things online and being able to manipulate them, initiating response inhibition, which is not responding immediately, but sort of holding your response and considering what the implications are, persisting, generating ideas, high-level attention, and awareness. So it's a whole lot of very high-level cognitive functions. One of the best definitions I've come across is by Keith Cicero, who's a neuropsychologist in New York, and he talks about them as being integrative, which is really important in cognition, functions that determine goal-directed and purposeful behavior. So for someone who's an occupational therapist, that's of prime interest. Superordinate, meaning they're organizing all of the other things that are going on in our brain in the orderly execution of daily life functions. So here's an example of maybe not so great executive dysfunctions. I'm not disorganized, I know exactly where everything is. The newer stuff is on the top and the older stuff is on the bottom. Unfortunately, that looks too much like my desk. Now, executive function and dysfunction is actually present in everyday life. So we're going to have a little bit of an interactive thing for a couple of minutes, and I'm going to show you how your executive functions can fail. So to do that, I'm going to use this neuropsychological test called the Sustained Attention to Response test. It's a vigilance task, so you're paying attention. And it's predictive of everyday attentional failures and action slips in people with brain injuries and in normal control participants. Now, an action slip may not be a term you're familiar with. On Sunday, my husband and kids and I were driving up to the Etobicoke Creek Trail to go cycling. We're going up the 427, and my husband and I were talking about, I don't know what we were talking about, but it wasn't about the cycling trip. And suddenly he goes, oh, I missed the turnoff, and veered across too many lanes of traffic for my liking. And I said, oh, that's an action slip. So he drives that route to work, not to the turnoff for the trail, but stays on the other side to go to his place of work in Mississauga. And we all do this. Do the routine. The routine is easy, and when your routine gets interrupted, you have to pay extra attention, and it's tiring. Yeah.
So that's the kind of thing when you show up at work and you realize you haven't remembered anything about the trip, you're just on automatic.
That's right. That's right. And if you were supposed to stop and drop in your dry cleaning and forgot, that's exactly that kind of thing. So we all do that. This test is predictive of those everyday tasks. And on this task, you have to respond to every target, but withhold to a rare target. So this is a response inhibition task. I'll explain a bit more. In the neuroscience world, we know that this involves arousal in the cingulate and noradrenergic system, and that goal representation, so holding what you have to do in mind, is the right prefrontal cortex. And I am going to talk a little bit about the brain in a few minutes. So this is a clapping task, and I'd like all of you to do it. Names of fruit are going to appear like this on the screen. And your job is to clap after each fruit name except for pear. Okay? Very simple. Are you ready? Mm-hmm. Okay. Okay, so I stole this idea for a talk from one of my colleagues, Brian Levine at Rotman, and I've used it a few times. He's used it a lot of times, and every single time when either of us talk, people always respond when they're supposed to inhibit. So that's an example of normal behavior, but it's a mistake, and we make mistakes, we make errors. So what's going on with this executive dysfunction in a sense? Why do we make those errors? And there's lots of theories about why we do, but I'm going to just talk about this one theory by Mesalem, which is called the default mode. And we've already kind of talked about it in terms of being in that routine, automatic space and not exercising the attentional control necessary to do something else. So Mesalem talks about it in this way. Instead of that superordinate control that our executive functions do, instead of that being exercised, our actions are driven by immediate gratification or environmental triggers. And in this case, the trigger was the clapping routine. The immediateness of the trigger interferes with the modulation of the behavior by the context or experience. And here's another example of a way where the environment may trigger a behavior that you actually want to inhibit. So to overcome this problem, we need to reestablish executive control. And there's really two ways in the rehabilitation world that we think of doing that. One is using what are called bottom-up strategies, and those are externally based cueing systems. So here's an example of that. And the other, which is what most of my talk is going to be about, is the use of top-down approaches, which are internally driven metacognitive strategies. So metacognitive is thinking about thinking, really. So it's very cognitive, it's making things explicit that might otherwise be routine. And here's some examples of metacognitive strategies that have been used over the years in the brain injury world. This is the last one here is what I'm going to be talking about today, goal, plan, do, check. And all of them have that kind of frame. So setting a goal, making a plan, implementing the plan either actually physically or mentally, and doing a check in terms of whether that plan actually achieves what you want it to achieve. We all do this. And for the most part, it's fairly automatic, but you probably can think of times where you have a lot going on, or it's a particularly complicated task plan that you're trying to make, and you may actually exercise this explicitly in a way, okay, what am I trying to do? Okay, here's my plan. Let's see how it works out. So I'm still on thread one of my background here, just to remind you, talking about executive dysfunction. There have been a fair number of studies done on this area, published in Systematic Review most recently in 2008. Very few randomized controlled trials, which are the sort of gold standard in the medical world, medical research. But all of the 15 studies that Kennedy found, all 5 of the randomized controlled trials, which are class 1 studies, and 5 others, so 10 of the 15 used metacognitive strategy instruction to teach people to regulate their behavior, to solve problems. Now, interestingly to me, and something I'm going to pick up on as we go through this, is none were contextual, and only one of those studies focused on client-centered goal setting. So we'll come back to that. So now thread 2, executive function in the frontal lobes. So the frontal lobes, so this is the brain. I don't know how many people are used to looking at brains here. This is looking at it from the outside, and if you cut it in half, this is looking at it from the inside. This is the frontal lobes made up of anterior, dorsolateral, mediolateral, or ventrolateral and mediolateral prefrontal cortex, but we're not going to get into that. So just the area of the brain at the front is known to be responsible for executive functions. Now, we do know now that there's lots of networking that happens, so it's not just the frontal lobes, but frontal functions are executive functions. We also know that this area of the brain is highly susceptible to the aging process, just normal aging. The neurons and cells seem to be more susceptible in that part of the brain. That's why when you put on your bike helmet, you want it to come to here. You know, you see kids riding around with their helmets up here. Just tilt it back. I'm going around getting my kids and their friends, move your helmet forward. This isn't part of the brain you need to worry about. So there have been a number of studies coming out, and lots more recently, this is in 2007, looking at this frontal part of the brain, problem solving or decision making and aging. And in this particular study, Denberg and colleagues found that in a cross-sectional study of community-dwelling participants, so these are relatively healthy people if they're still in the community, demonstrated that a sizable subset of older adults, 35 to 40% of their sample, performed disadvantageously on a laboratory measure of decision-making that closely mimicked everyday life. So we know, we think of aging, and it's always memory you think of. People have memory problems as they age. In fact, people have executive function problems too, and these are seen like in multitasking. I notice in older adults that I know, it's harder for them to do a lot of things at the same time. Even myself, and unfortunately, these functions start to deteriorate at quite a young age.
The age doesn't occur. At what age when you say older adult?
Well, I'm not sure what the age cutoff in this study was, but really executive dysfunctions, they kind of peak in your mid-20s.
Already?
Yes. And then, so really up to they're still developing up to your early 20s now. We found that sort of around, it used to be thought, and that's why teenagers behave the way they do, because they don't have this superordinate control over their actions. Anyway, but certainly we don't see really huge changes until people are in their 60s, 70s. And some people you don't see them. It's not everybody, but there's certainly a large subset of the older adult population that appear relative to younger adults have executive dysfunction or have difficulties with perform at a lower rate. I don't like calling it dysfunction because it's normal, but it's part of the aging process. So what's the impact in the real world? And a number of people have looked at this, and the impact is substantial. More falls, poor driving performance, reduced comprehension of medical information, and reduced ability to perform a number of instrumental activities of daily living, so more complex daily living tasks. Those are just some of the studies that are coming out. And it's a relatively new area that sort of people are thinking about aging and executive dysfunction, so there's still lots of work to be done in terms of understanding what it actually means in people's performance. So thread 4 of my talk, so we now know, okay, executive dysfunctions, what they are, related to frontal lobes in the brain, which are sensitive, particularly sensitive to the effects of aging, and there's age-related performance changes attached to those. So now I'm going to move into, okay, what about ideas that would influence how we would address those? And I certainly come from an occupational science and occupational therapy background, so meaningful occupation and well-being is one thread that certainly comes in here. Now there was a huge study, well there's a program in the US, I don't know if you know about this, this is like the kind of thing, I wish I had thought of this idea. It's called the Experience Corps. And what this program does, this is the website at the bottom, they get older adult volunteers to go into primary school classes and work on literacy with the children. And there's a huge number of studies about this, but this was one of them that's looked at the impact on the aging population. In the pilot trial, physical, cognitive, and social activity increased, suggesting the potential for the Experience Corps to improve health for an aging population and simultaneously improve educational outcomes for children. So it's a really powerful effect. And I'm gonna just switch to this little video from I'm not going to play the whole video.
In this study, the changes that the Experience Corps volunteers had over a 2-year period with a normal sample of older adults that participate in nationally representative, every 2 years, longitudinal assessments of aging. Because it's difficult to think that a program is going to make people more physically functional. It's not going to keep people from experiencing some of the medically related changes that occur in later life. The idea is to keep people maintaining function, right, and maintaining activity as opposed to decline. And we found that in the measure of function that we use, the Experience Corps folks actually went up a bit, while the nationally representative sample was going down, and those differences were statistically significant and quite clinically significant. It was quite a big difference. So when we queried the older adults about their ability to walk and stoop and sit for long periods of time and lift their arms over their head, the Experience Corps people actually gained function while the normal group was going down. And that was the same pattern that we saw in terms of depressive symptoms, that the Experience Corps group actually improved in their mental health, that they had less depressive symptoms over time, while the nationally represented comparison group had more symptoms over time.
So, I wish that was my research. It's not, but it causes one to think about why this would have such positive benefit for older adults. And I think one of the reasons is related to the salience or meaningfulness of the occupation. So these are volunteers, and typically people volunteer for things they're interested in, and they're doing things that are meaningful to them. And when we look at the literature on goal setting, meaningful goal setting, we see that people make greater gains when the goals they're working towards focus on activities that are meaningful to them. I mean, it makes sense. Setting specific goals, and particularly ones that are a bit more challenging rather than easy or non-specific, produces higher levels of performance. And autonomy and self-efficacy is enhanced. So that's one example where I think we can infer that meaningful occupation is really critical, and it's supported by literature and various other places. So client-chosen goals. In the rehab world, we all talk about using client-chosen goals, but when you actually listen to what people are doing, it doesn't always happen. So I like to use this little cartoon to point out how we need to think about client-chosen goals. So when you look at this picture, think of yourself in that situation. What's going on? What's the goal?
To get the raft afloat.
To get the raft afloat, okay. But for these women, that wasn't what was important to them. And that's often the case when we're with our clients. So the next thing I want to just think about a little bit is context. So again, in the Experience Corps study, people were working in their own neighborhoods in a context that they were familiar with, and I suspect that had something to do with the impact. But we also know from neuroscience that everyday problem solving potentially draws on social and emotional processes linked to the prefrontal cortex, again that front part of the brain, and responsiveness to environmental cues, so what's around us, is mediated both through the emotional and cognitive pathways. So the environment is important in relation to our cognition, and the prefrontal cortex is where our decision making is going on. So it's not immaterial, the location that people are in. And again, there's I think I missed a slide here, so I'm sorry, but there's evidence from other places that suggests that context actually has a huge role. So we know that if you do an ADL assessment, a kitchen assessment with somebody in the hospital and at the home, on average people will perform better in their familiar environment. There's a number of studies in brain injury now, I think there's 4 that I've found that show that community-based therapy has at least as good an effect as in hospital therapy. In different, there's a lot of caveats around that, but it's surprising when you look at it, and there's neuroscience that suggests why, and we have a lot of empirical evidence to support us too. So those threads, executive dysfunction, frontal lobes, aging, impact of executive function and aging in the real world, and thinking about meaningful occupation and context, brought us to the rationale for this study. So the normal deterioration of executive function makes planning, organizing, multitasking, and self-monitoring necessary. It makes those things harder, and thus staying engaged becomes harder, because we need that to stay engaged. Thus some seniors, not all, but have more difficulty maintaining and managing their daily activities. And in turn, if you start having difficulties, then your sense of self-efficacy and optimism and perceived control deteriorates, and that also feeds into disengagement as well as cognitive decline. So we know now that these psychological factors play a big role here. So we wanted to address these. So the purpose of our study is to maintain autonomy by enhancing older adults' participation in daily life abilities, and through this to diminish and/or prevent deterioration in executive control. And the way we went about this was by refining a strategy training intervention that I'll talk about in a minute, but I've been using in brain injury, and then undertaking pilot work investigating its efficacy for enhancing older adults' participation in daily life abilities. Our methods were these. We have 2 phases to the study. The check marks indicate the phases that are complete. So the first phase was a single case study that one of my graduate students did to even look at would this even be something an older adult would participate in, would they find it beneficial. Then we developed our protocol manual, and we reviewed the manual with a number of older adults who would be eligible for the study to get their feedback on what the manual looked like, the content, the level, and so on. Phase 2 is a pilot randomized controlled trial, and we're about halfway through this now. We had 10 people are being randomized to receive the metacognitive strategy instruction, and 10 people are receiving education and cognitively stimulating games, both in the same environments, the same amount of time, by the same person. So all of that is controlled. So what is our metacognitive strategy instruction that we're using? Well, we're using something called the Cognitive Orientation to Daily Occupational Performance, or COOP for short. And this is a client-centered, performance-based, problem-solving approach that enables skill acquisition through a process of strategy use and guided discovery. And I'm going to unpack that because it's a lot. It was originally designed by Helen Polatenko and Angie Mandich for use with children with developmental coordination disorder. And the first time I heard Helen talking about this, she's on faculty here in OS and OT with myself, and who's our next chair. So the first time I heard her talking about this, I said, this sounds really like some of the stuff we're doing in brain injury, and I'm sure this approach would be effective in people with traumatic brain injury. So we did some work that shows that indeed it is, and also in people with stroke, both for motor problems, and now I'm working with someone in Pittsburgh who's using it with people with stroke for their cognitive issues, and the pilot work is also showing quite a lot of promise. So it's very exciting. Here are the key features. The first thing is the participant is active in identifying their treatment goals or their strategy training goals. And active is even perhaps not stated strongly enough. They do identify their goals. We help make them more specific sometimes, but the goals are theirs. In the older adult study, we've added some education about executive function and self-management, because we're really aiming to have people developing skills that will build autonomy as they age. We teach them a global strategy, goal, plan, do, check, and guide people to discover domain-specific strategies that will move them towards goal achievement. So let me just talk a little bit about these 2 things to unpack them a bit more. So the global strategy is the metacognitive strategy. Set a goal, make a plan, do a plan, check a plan. So if in one of the people we use this with who had traumatic brain injury, his goal was to be able to cook a meal for the 5 people he shared a living space with. And that involved for him, because that can mean a lot of different things. For him, it meant choosing the menu, buying the ingredients, cooking the meal, and cleaning up afterwards. When it got to the cooking part, he had 2 big issues. One was that he couldn't find the ingredients for things, and the second was that he would forget what he put into the pot. Like if he was following a recipe, he would lose track of the recipe. So in relation to the second one, where he was forgetting things, he's still in his goal, plan, do, check. He's got his large goal in his plan. The domain-specific strategy here, the therapist would say to him, so what do you think you could do so you don't do that? So this is the guided, as opposed to telling, you know what, if you check it off, you won't forget. That's telling. The guiding is, well, what do you think you could do? And he came up with the strategy himself. And what we think happens from that process is that people build a lot of self-efficacy, because it's their plan, it's not the therapist's plan. They came up with it, they can check if it's working for them, and it seems to make a huge difference in the way people develop performance skills and in the follow-up. So he came up with that plan, and indeed that plan worked, and he carried on using it. And in terms of the amount of cueing he needed through the cooking process, it went from the beginning of our intervention from about 20 or 25 cues to 2 or 3 over a 10-week period. And this was someone 20 years post-brain injury, so it was a huge effect. But I'm not talking about brain injury today, so we'll carry on. So our major objectives in this study were goal achievement, learning to use the strategy, and then transferring generalization. Now this is really, really critical in any of rehab or strategy training. Like, we can all teach someone to achieve a goal, but if you can't have a strategy in place that they can carry over into other situations, because therapists and allied health professionals and paraprofessionals can't be there in every context. So really the ideal is to do something that will generalize. So I'm going to talk a little bit about how we do this then. So first is the goal setting process. And what we use for this is a semi-structured interview called the Canadian Occupational Performance Measure. This, the psychometrics on this are quite solid. And it's basically in 2 parts. So the first part is, do you need to, do you want to, are you expected to do X, Y, or Z? People identify what that is. Can you, do you, are you satisfied with the way you? So if there's any no's to this, can you do it? Do you do it? Are you satisfied with the way you do it? But you need to do it, but you can't do it. Those become the things that we identify to work on. So that's the first part of the process. And then we get people to rate their importance. If it's not important, then, you know, who cares? But the fellow who was cooking the meal, he was, the referral to our study was made because the caseworkers or the group home workers wanted him to clean his room. That was their goal. He really had no interest in changing the way he cleaned his room. So, you know, we found that out. I mean, it was pretty obvious when you're talking to him, but when he rated his importance, that also became clear. Then we asked people to rate their performance and their satisfaction. So someone's performance can be, you know, a 4, but they're satisfied at a 10. Again, it doesn't become a place where you think you're going to make any change. They're totally satisfied with the way things are. So we're really looking at things that are important, but performance and satisfaction are low. Satisfaction with performance. Another thing we use in this approach is these support sheets. So we ask people to be very explicit about everything that's going on. So they have their large goals, and every time the facilitator meets with them, they make plans to work towards that goal, and they state what the evidence is going to be to know if the plan worked and check whether the plan worked. So it's all about developing plans and determining if they work or not. It's not about me as like not being able to do something or being able to do something. It's about whether the plan worked or not. So the other thing we found is it takes away some of the self-criticism and self-blame and promotes an efficacy, because I'm making plans and I can determine if they worked or not. And we all have different plans. In our healthy older adult group, the first group meeting we had, the first part of the study, we gave the example of if your goal was to have a cup of coffee you enjoyed, now make a plan for that. And if you just mentally think of your own plan for getting a cup of coffee you would enjoy, I think it's pretty straightforward. But the 4 people in the group, there were 4 different plans. So one person had a very, she really liked fine coffee and it had to be ground in a particular way, and she had a little cinnamon and she had a particular way to brew it. And another person in the group went to Tim Hortons. It's fine. We all have our preferences, but it's important to look at those. So our training session in this study went like this. It was pre-test. Then in week 1, they have a 3-hour group session. And in that group session, we talk about executive functions and aging and introduce the strategy and get people to, the goals are identified at the pre-test, but we come back to those goals and try to make them a little more specific. And we ask people to identify 5 goals ahead of time, 3 of which we train on and 2 remain untrained. So we evaluate whether there's been any carryover to the untrained goals at the end. And weeks 2 and 3, everybody had an individual session with a facilitator in their home. So we go to them, we go to their environment, their context. And we think that is beneficial because sometimes we do the plans with people, like in the case of cooking, we're there while they're cooking, or if they're exercising, we can exercise with them or whatever. We don't know what their environment is like if we're not in that environment. Week 4, we had another group session, review of the education, and then also trying to sort of build some group rapport and encouragement. Then weeks 5 to 7, 5 individual sessions, and week 8, 2.5-hour group session. And I actually have a video clip from this session, which was Tuesday, so 2 days ago. So it's really hot off the press. Then we're just doing post-tests on these people, and we'll do a 3-month follow-up to see what the carryover is. So our participants in this study were healthy older adults. 60 was our cutoff for this, living in the community. They all had to test relative to their age and education as having normal cognition. So we defined that as 1.5 standard deviations away from the mean on the standardized testing. However, they also had to have subjective cognitive complaints. So we have a cognitive failures questionnaire and ask people to go through that. And if there were complaints there, but they had normal cognitive function on neuropsych testing, they would be eligible. Plus, no depression, no history of serious psychiatric disease, and no history of neurological disorder. So we were trying to have a pretty clean sample where their functioning could only be attributed to aging or their problems with functioning. Now our desired outcomes, first of all, were goal achievement on trained and untrained goals that would show us the generalization and associated positive changes in activity and participation limitations, meaning fewer limitations. And then our secondary outcomes, reduction in cognitive complaints, improvements of locus of control and self-efficacy, and improvement in executive function as measured on neuropsychological assessment and questionnaire. Now, I don't have data on all of these. I have a little bit of data from their case study that my graduate student did. So this is a 78-year-old male with subjective cognitive complaints. He identified some high-level activities of daily living difficulties. And he got 14 hours of individual sessions. So these are the goals that he identified. To communicate using Skype, to organize the files in his house, to download music onto a CD. And these are the ones that he was trained on. And he identified 3 more goals: to expand his volunteer activities, to increase correspondence with friends, and to organize a schedule for all of those activities. And then we also looked at self-efficacy. So the train goals, just before I show you the data, we looked at performance change, and if you remember, the scale was 1 to 10. So what you're going to see here is the change. Previously, people have established that a change of 2 points on that scale is clinically significant. So for our train goals, +8, +2, and +7. So huge performance changes for him. Now this is self-report, but still, he's a healthy older adult. And our untrained goals, +5, +6, +2. So really very fulfilling as, you know, being on the end and getting the data of this. And self-efficacy, whoops. Don't tell me I don't have the, oh my gosh, now what have I done? Okay, hang on. My technological skills are not. You're just like biting your teeth now, right? Waiting to see what happens with that self-efficacy score.
It's beautiful.
And I may not have rigged this right to do that. There we go. +6. So also very promising in terms of what we're trying to achieve. So a few important points about using this type of intervention. The client identifies the goals. The therapist facilitates making them specific. And we have never, we haven't done tons of people, but we've used this now with about 20 to 25 individuals, and we've never not gone for a goal that someone has set. We've never said you can't do that. And the goals have ranged literally from putting on my shirt to planning a wedding. So huge range of goals. Developing the plan is the client's job. The therapist guides the plan formation. The client, we want them to learn that there's many plans, some work and some don't. The therapist does not prejudge the plan. And the client identifies evidence for success a priori. The therapist guides the process, provides positive reinforcement using the co-op language, which means not saying, wow, you did great, but what a great plan you came up with. That worked really well for you. It's subtle, but it's really important, I think. Yes.
So for the goals that the people received training on, what did that training look like? Was it helping with the plan and
Yes,
just like
so it's
literally
guiding the
writing
plan,
it out
yes.
and
So,
step by step? Like anything?
I don't think I put in. Okay, so I didn't put a slide in terms of what our sessions look like. But we've given everybody a binder that has a number of divisions in it. But there's a division for each of the goals we're working on, and we use those sheets. So when the therapist goes in, we try to work on generalization right from the get-go. So once the person understands the large strategy, the global strategy, a session will start with the therapist or the facilitator asking the participant, so have you used that at all this week? Tell me how you've used it. And if you haven't used it, can you think of any way you might have used it? So we immediately try to get people thinking in the language of it. And then we say, so where would you like to start today? And they have to identify which goal they want to start with. Okay, well, you know, what was your plan? So the therapist really sits back and guides the process. We don't write anything down for the client. They write their plans down. And the plans often become the homework because the plan may not happen within the session. So for example, I'm just trying to think around the wedding plan. So one week, the plan was this woman was having a little bit of conflict with her maid of honor around dresses. So her plan was to talk to the dressmaker and her maid of honor and resolve that conflict. And another plan could be, this person who wanted to get his shirt on, he was very severely impaired with a brain injury, physically and cognitively. And he also wanted, by the way, this was also someone who's like more than 10 years post-injury. He went from not only getting his shirt on, but also getting himself into the bathroom and doing his morning self-care and downstairs and making scrambled eggs, which was amazing. And his parents and he were really very happy about that outcome, as were we. So his first plan in terms of transferring was, well, I'm just going to transfer. And his dad was like, no, you're not. So we said, well, okay, but we probably need to put a few things in place so that your dad's comfortable with that plan. And, so we put that stuff in place. And the plan didn't work for him. He couldn't just do it. He had to have steps into it. So we would, some people find if you put the chair like this and the brakes on, it really helps them with the transfer. In my experience, with other people I've worked in, I've noted that they try this. I don't know if you want to try that, but you can always try it. So that's the kind of guidance we do, as opposed to positioning the chair, putting the brakes on, and I've done all that stuff as a therapist. I worked as a therapist without using this for 10 years. So we go through we try to go through at least two of their goals in a session, and depending on the person, it takes, with people with brain injuries, sometimes we'd only get through one in a session, depending on how quickly they were able to process the information, how much of the doing they were doing with them. We found with our healthy older adults, the sessions were much shorter because they were able to generate their plans and let us know what the homework had been much more quickly. So some of the sessions were like 30, 40 minutes. We probably didn't need as many, but we'd never done it before, so we start with that. And then we wrap up by saying, and how will you use it this coming week? So we always have that aspect of generalization. And the other part of that is, as we get towards the end of the time with our participants, and with the people with brain injury, we usually start this about session 15 out of 20, and say, okay, so how are you going to keep doing this once we're not here? Because that's a really important part of the process. Who's going to be your person to be accountable to? Anne Hunt was the clinician who worked with me on people with brain injury, and she had 20 years of experience as an OT before coming and working with me on this. And this is what she said about it. I continue to be amazed at how this seemingly simple strategy is really life-changing for some of these participants. It appears to work exceptionally well for those with time management, organization, planning, and initiation deficits, executive functions, and memory problems to a degree. So that was very exciting for her. But now this is from the participants, sorry. And as I say, this is from Tuesday of this week, so it's where we were asking them about how things have gone through the session.
We were talking about morning journaling. I don't do it consistently every day, but I find when I do sit down with my coffee and start thinking about the things I want to do, the things I need to do, I'm beginning to include this type of goal planning to check as part of that. And that's beginning to work to my benefit. And I've always done that with the things that I have to do, but now I'm including things I would like to do. So that's a different, that's like a step in the right direction for me. Because the things I would like to do have always kind of floated around there and often don't get attention.
Yeah, so I know what the goals are, but if I don't ever go any further than saying I'd like to do this or I must do this, I still don't do it. But it's kind of the steps that I find really helpful, writing down the steps. other things that I really wanted to do, then it's kind of constantly, okay, how will I do it?
That's leading to my day, to my week. I know that I'm working towards something concrete, not just something that's, that can change because it's never being stated. It's just floating around up there. Yeah. And also at the end of it, with did I do the plan? Did the plan work? I can stroke myself and see accomplishments, and that adds to my feeling of self-worth.
I told her that she was our study poster child after she said that. So it was totally uncued, I can assure you. So in summary, we think this approach shows promise for facilitating older adults' participation in meaningful occupations, both trained and untrained. And I was really delighted on Tuesday to hear 3 of our 4 participants there talk about not just doing the things they had to do anymore, but thinking about what they wanted to do. Our anecdotal evidence in our case studies suggests increased self-efficacy, and we'll have more data shortly, which I hope will support that. So we think that we can and should manage, assess executive dysfunction with the overarching purpose of enabling people to perform meaningful real-world activities and occupations. But of course, there's lots more questions. What are the key active ingredients? That's always a big one. Dosage, how do we, can we maintain it? Can we enhance the self-efficacy effect, make it even stronger? Group versus individual, we don't know which works better. Thinking about who benefits. One of the 4 people in our group didn't think they would use it again. So we're just trying to get out, well, what might be different about this person than the other 3? We don't really know at this point. And you probably have your own questions, which I hope you'll pose. So I'll just end with this. I think age is opportunity no less than youth itself, though in another dress. And as the evening twilight fades away, the sky is filled with stars, invisible by day. So thank you, and I'm happy to answer any further questions.
I have a question, although I hope I worded it well. I missed the beginning of the talk, so maybe, and I don't know a lot about occupational therapy, but I was just wondering that from what you've said, I gather that this program has been effective because the OT is working with the individual so that they can sort of self-actualize a plan as opposed to kind of giving instruction or something like that. From an aging background, I guess I was just wondering whether so this is more general, I guess, is simply having another person there to provide encouragement and to ask certain questions, to what extent do you think that really could also make the difference?
Well, there's a couple of parts to that, so I want to address. I mean, the first thing I want to mention is that with our healthy older adults, it's not an OT doing the work. Okay. So my research assistant is a woman who's working for me. She's a Bachelor of Science, and we've trained her, and myself and another trained OT are giving her feedback, but she's actually running the program. We also did a few of our brain injury clients with a paraprofessional, because I think it's really, OTs are expensive, and this can be a pretty time-consuming process. Even in the community, a lot of people with brain injuries don't get that much service from public health care. So we wanted to look at ways that we might be able to do it in a more sustainable fashion. So that's part one. Part two is this study is a randomized controlled trial. So we have a second arm of the study where everybody's getting exactly the same amount of time from the same person, and the same amount of groups, the same amount of individuals with a different activity. They're getting education and cognitively stimulating games. So they're doing word searches and word scrambles and Sudokus and that kind of thing. I don't know, because I don't have the data yet. I mean, we just finished the intervention part, and we're starting the post-test next week.
Okay.
So maybe, next year I can come back and give you those data. What I'm anticipating is that both groups will improve in certain ways, but that our the group getting the strategy training will improve more, certainly on their performance changes on their goals. I'm also anticipating improvements in self-efficacy that we won't see in the experimental group or in the control group. But I'm not sure. The truth of the matter is, in a lot of rehab studies now, and studies I've been involved in at Baycrest, the control groups are also getting better. And I asked Yael, who's doing the intervention for me, in the control group, not to be too engaging. Because I think engagement, like that, the act of engaging somebody and getting them engaged is very therapeutic.
Yeah.
So when I'm looking at key active ingredients, I think that's one of the key active ingredients. And it's really hard to run a control group without having that happen. But she told me people were complaining in the control group about some of the sessions. I said, good. Because we want to try to maximize the effect in the intervention group.
Do you have any plans to try this intervention with other populations? Like, I'm thinking of people with depression could really benefit from this.
Yeah, I think so too. I think there's we've done a lot of pilot work now, so I'm hoping to be able to do some larger studies to really establish the efficacy, because it's still, this is very, very preliminary, and in terms of evidence-based practice, we don't have the evidence yet to really say, we should be doing this. So that's one direction I'm seeking funding in. It's all about funding. The other is looking at, okay, well, what are the active ingredients here? And I have some ideas about what they are, but I don't know that the whole, I think some things need to be added to the package. So the goal setting piece, goal setting is part of executive function. But the only thing that we do around goal setting is facilitate that process at the beginning, but the intervention itself doesn't involve anything around further goal setting. So I have a doctoral student now working on that for her dissertation. So we're trying to really tease out, okay, what's really critical to get generalization. We have done, now we've worked with people with brain injury, acute stroke, subacute stroke. Another doctoral student who's actually at McGill, working with a colleague there who's doing more work in stroke. We've run a group study with people with mild cognitive impairment, and we've just started the healthy older adult group. And we've done one case study with someone with obsessive compulsive disorder, and it was hugely beneficial for this person. Hugely beneficial. I think it would work with depression. So if somebody wants to give me money to try it, I'm happy to try it. In fact, I think one of our participants, she didn't test as depressed, but when I met her at the beginning, to me, she showed some of the signs of depression in terms of the flat affect, and she talked in the first group session about feelings of worthlessness and things that I would associate with depression, and I didn't see any of that in the last session. So I don't know what her depression score, how it will be in the post-test. But
what was the scale?
We used the CESD, Center for Epidemiological Studies Depression Scale, and we had a cutoff of 16, which is still, that's clinically significant depression, but people could still be showing signs of depression at lower scores.
And how did it work with the mild cognitive impairment group?
For that study, I'm just waiting to see the data. I wasn't the PI on it, but we used this. It was we ran a study at Baycrest a number of years ago where we had three cognitive modules. One was strategy training. It wasn't this type of strategy training, it was another type of strategy training. One was memory training, and one was psychosocial intervention to look at encouraging people to exercise more more control, choose more adaptive coping behaviors. And we ran all three of those together and then looked at pre and post and saw quite positive changes. So the MCI study mimicked that. So we can't tease out the effect of this specifically. So overall there were some positive effects, but whether we can attribute them directly to this strategy training, we can't at this point. So it's still early days. It all takes so long. get the funding to study, ask for more funding. Any other?
Was there any relevance to what they had done as a work before they retired? Or their level of education as far as?
Yeah, they're all quite educated, like university educated participants. We have their work data. I haven't looked at that data in relation to the outcome yet. I tried to ask them about that on Tuesday, because there were. Interestingly, it kind of fell along gender lines because we had 3 women and 1 man, and the women were all talking about being organized in their work life, whether it was homemaking or outside. One was a homemaker, and the other 2 were employed outside of the home, but not being organized for their personal things, and finding this was really helpful in terms of the want-to-dos that they had not really paid attention to. And the man had a job that had been very structured and seemed to have carried that over into his personal life, and so he didn't talk about this. He didn't find it as helpful in terms of the self-report of the last group. I'll still see what the data say at the end. I'm a quantitative researcher, really, by heart, so I'm always going to look at the data, but the qualitative piece of it is nice. It's a really important question, though. We're actually doing another study at Baycrest on the benefits of volunteering as well, and particularly looking at whether volunteering can prevent cognitive deterioration as well as overall well-being. So what we're doing for that is we've coded all of the volunteers' pre-volunteer work roles. There's using the NOC. I don't know if you know occupation code, but it's an occupation code that looks at the sort of amount of physical and cognitive exertion and social stimulation in a job. We're now coding all of the volunteer positions using it, and that will be a factor in the analysis that we do at the end. Well, thank you very much for your attention. If anyone has any further questions at a later point, just email me and I'm happy to respond.
Thank you very much.